Here on GameChangers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting CEimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count.
Hey CEimpact subscribers, and welcome to the GameChangers Clinical Update Podcast. I'm your host, Rachel Maynard, and we've got a jam-packed lineup for our discussion today. We'll be covering a variety of updates related to hypertension. That's because a new guideline on the prevention, detection, evaluation, and management of high blood pressure in adults was published from the American College of Cardiology and American Heart Association and other organizations late last year. So we'll highlight what's new with those guidelines. Plus, there have been a few interesting scientific statements released from the American Heart Association, also late last year, which are raising some new questions about issues such as single pill combination therapy for managing hypertension and cuffless devices for measuring blood pressure. So to navigate some of these changes and updates and how they'll fit into practice, I'm so excited to introduce our guest today, who's an expert in cardiology, Dr. Tom Jurga. So welcome, Tom.
Hi, how are you?
Great to have you. Very excited to have your expertise in this area. Maybe for our audience, you could share a little bit about your background, your current role, and why you're interested in this topic or passionate about it.
Absolutely. So, first of all, thank you for having me on this podcast. I'm very excited to talk about all the updates and the statements from the 2025 hypertension guidelines. So, like you introduced, my name is Tom Jurga. I am a cardiovascular pharmacist. I specialize mostly in chronic cardiovascular conditions, hypertension, of course, dyslipidemia, heart failure. I work at Ann Arbor VA, so I mostly work with veterans. And again, most of my practice focuses on chronic conditions. So I spend most of my time managing medications, performing comprehensive medication management for veterans with heart failure, hypertension, dyslipidemia, coronary diseases, and so on. I'm also the PGY2 cardiology pharmacy residency director for our facility. So I currently have my first resident, and we are trying to improve outcomes by engaging in research on multidisciplinary care at the VA. So we're really trying to focus on not just patient outcomes, but also how pharmacists, nurses, cardiologists can come together and improve these outcomes through multidisciplinary approaches to medication management, screening initiatives, and things like that. So I'm really excited to talk about this topic because hypertension is kind of an important topic. Um, as I'm sure most of our listeners know, almost half of adult Americans have hypertension, and we can talk more about this as we go on through the guidelines and the statistics. But quite a few of those patients either don't know they have hypertension, or if they do, it's very poorly controlled. So definitely excited to talk more about this topic.
Yeah, well, thank you so much for that intro. This is definitely in your wheelhouse, I would say that, very close to your practice and what you're teaching. And I also love how you have the focus on interdisciplinary care and working as clinicians together to improve care for patients. I think that's going to really resonate with a lot of our listeners too, who are, trying to model that approach as well. So great to have you. And let's go ahead and start with I mentioned a few different resources. So the guidelines, but also a couple of scientific statements. And as you said, hypertension is a huge topic. So we're going to try to tackle some of the highlights with these. But if we start out with the recent hypertension guidelines, these 2025 guidelines were updating and replacing the last set of guidelines from that same group, which were published in 2017. And it's a large document, big set of guidelines, but what would you say are some of the main takeaways that our listeners should be aware of from these guidelines, and what's changed from the 2017 guidelines?
Yeah, that's an excellent question. So when the 2025 guidelines were published, there are a few new statements that are completely brand new to the 2025 guidelines that didn't exist in the 2017 version.
Okay.
And then there's been quite a few updates. So I would say the most important takeaways for our listeners are some of the new recommendations. So I guess let's focus maybe on, let's go through these in a logical sequence.
Okay.
So, first and foremost, screening.
Mhm.
Some of the new updates talk about screening for patients with hypertension, and not just measuring blood pressure, of course, but also really thinking about comorbidities that exist with hypertension. So, when you are dealing with patients with high blood pressure, you also want to screen for things like thyroid disease. You want to screen for things like renal disease. So not just checking a basic metabolic panel to look at the serum creatinine, but also performing a urinary microalbumin test to see if there's any albuminuria in the urine,
Okay.
because that can really guide treatment. Another thing is, thinking about thyroid conditions, liver conditions, evaluating lifestyles, diets. So all of those things really go hand in hand in trying to not just manage medication therapy, but also performing proper education on lifestyle changes.
Hmm.
So beyond that, beyond the
Actually,
initial,
before you move on, I don't want to interrupt your train of thought, but let me just ask you quickly. So the focus on screening for those other comorbidities and other conditions is not only to identify potential secondary causes and what might be contributing to underlying hypertension outside of, primary hypertension. Is that fair to say? Like this is one of the benefits of screening and identifying some of those other issues, or is it mainly to help guide therapy recommendations if you are identifying some of those other issues?
that's
Sorry.
actually that's actually what I was segueing into,
Oh,
secondary
perfect.
forms.
Great.
Right.
Okay.
Yeah. Yeah. So yeah, I know that was my long-winded way of
No,
segueing
no.
into secondary hypertension. So
Gotcha. Okay,
um,
okay.
the 2017 guidelines definitely talked about secondary hypertension and resistant hypertension, but the 2025 guidelines make some new recommendations about those topics. So when we're doing this initial screening, basically what we're doing is we're not delaying screening of those secondary forms of hypertension. And then just to review, um, we're kind of stuck with these definitions of primary hypertension
Mm,
and essential hypertension. But what we're really ignoring with those definitions is that a lot of patients do have secondary causes for hypertension. And the most common causes of secondary hypertension are things like obstructive sleep apnea,
hmm
things like
hmm
primary aldosteronism, and things like renal disease. If we think back to our times in pharmacy school, we might remember buzzwords like pheochromocytoma, aortic
hmm
coarctation, Cushing's disease, but those don't contribute as much to secondary hypertension. For sure, they're very, very important because if somebody does have pheochromocytoma, you definitely want an endocrinologist to be involved. But again, most of the time, patients have chronic conditions like OSA, primary aldo, and renal disease. And these can account for about a third of all causes of hypertension. And so a lot of patients don't just have OSA or don't just have
Right,
renal disease. A lot of these
right.
patients may have,
hmm
multiple comorbidities.
hmm
So
So,
when we're thinking about screening for these secondary forms of hypertension, the 2025 guidelines like really focus on early screening for primary aldosteronism,
okay,
and these new recommendations in the 2025 hypertension guidelines actually go in line with a different guideline that was published by the Society for Endocrinology, because
okay.
they did a little tweak in recommendations for screening for primary aldosteronism. And why does primary aldosteronism matter here? Because when you're secreting aldosterone, which is what primary aldosteronism is, that revs up your renin-aldosterone-angiotensin system, and that causes, of course, more vasoconstriction, and then, of course, high blood pressure. So a lot of people with primary aldosteronism may have sudden spikes in blood pressure. They may have gone their whole lives with normal blood pressures, and then all of a sudden they have higher blood pressures, like in their 30s and 40s. So that's a nice red flag to be aware of when you're
hmm
discussing these sorts of things with your patients.
hmm
And then the biggest update is performing the actual screen, because previously there was really no recommendation in the hypertension guidelines about doing the screen for primary aldosteronism, but now it's in line line with the 2025 endocrinology recommendation for primary aldosteronism, which basically states that when you have somebody with high blood pressure, do the screen as soon as you can and
Okay.
don't wait until you're adding the fourth agent to your
Right.
blood pressure regimen.
Okay.
And and pharmacists can really be involved in this because they can make these recommendations. If you work for centers where you have the ability to order labs, you can perform a serum aldosterone and a renin activity screen to get the aldosterone renin ratio in order to see if somebody has primary aldosteronism. And just remember, whenever you're recommending this screening lab, it has to be done first thing in the morning. And previous recommendations mentioned that you have to wean people off of ARBs and ACE inhibitors and spironolactone and other aldosterone antagonists. But now the recommendation is you can keep people on ACEs and ARBs, even though we know it might cause a little bit of a false negative, but definitely do it before you add on the aldosterone antagonist, because once you have the aldosterone antagonist, that might really
Sure.
cause a false negative. So,
Sure.
so
Sure.
that I think that's one of the bigger takeaways from the 2025 guidelines, that early screening for primary aldosteronism.
Sure, sure. Okay. But yeah, really good to know that there is this focus on being proactive screening before even initiating treatment and being aware of some of these potential comorbidities that could be contributing to hypertension, and again, how that might affect management too. So that does seem like a really important takeaway. And as you said, new recommendations from the guidelines. So thank you for calling those out. What other changes do we have to be aware of?
Um, the so now when we're going past screening, and
Yep.
the biggest change in the guidelines is actually the treatment pathway.
Okay.
Um, so let's spend a little bit of time talking about this. So as we know, previously in the 2017 guidelines, the goal blood pressure was less than 130 over 80, and
Mhm.
treatments typically started for patients who have stage one hypertension. So again, to review, normal blood pressure is less than 120 millimeters of mercury over 80 millimeters of mercury, systolic and diastolic. Elevated blood pressure is a systolic of one between 120 and 129, and then stage one hypertension is a systolic above 130 over 80 diastolic. And then
Mhm.
stage two is a systolic above 140 over 90. So
Mhm.
in the previous guidelines, the recommendation was to start therapy for people who have stage one hypertension and
Mhm.
have comorbidities, or those patients who have a 10-year ASCVD risk score of greater than 10%. Right. So I remember back in 2017, there was a lot of discussion about this because it seemed like it included a lot more patients that require medication
Mhm.
therapy. Because remember,
Mhm.
previously the GNC 8 guidelines had a lot more lax recommendations for blood pressure screening and blood pressure goals, less than 140 over 90 for the most part. And then the 2017 guidelines really big had a big shift in blood pressure goals and initiation of treatment. And that 10-year risk score really made a big difference, because if you are somebody who doesn't have risk factors for cardiovascular disease, somebody who doesn't have cardiovascular disease, then if your blood pressure was in the 130s over 70s, or even over 130s over 80s, then you didn't necessarily require medication
Mhm.
therapy right away. The
Mhm.
guidelines mostly focused on lifestyle modifications and then reassessment within a few months, within 3 to 6 months. And then the 2025 guidelines, they tweak that a little bit, because not only do we have a new calculator that's recommended by the 2025 guidelines, but we also have a new goal.
Okay.
So the previous guidelines use the pooled cohorts equations to calculate the 10-year ASCVD, atherosclerotic cardiovascular disease risk. These current guidelines actually are the first guidelines to endorse the new calculator called the PREVENT calculator that was released by the American Heart Association.
Mhm.
And the PREVENT calculator differs immensely from the pooled cohorts equations. And you can
Okay.
find the PREVENT calculator on the American Heart Association's website. It utilizes a few different figures. So it uses some similar inputs as the cohorts equations, like age, like blood pressure, of course, but it goes away with race as an input in the calculator. And we can
Okay.
talk about race-based recommendations for hypertension, at length later on, but that's the biggest change in that calculation screen. And then the calculator also looks at other things like BMI, like A1C, like the urinary albumin creatinine ratio, so a marker of kidney disease. So it
Mhm.
really focuses on that cardio, renal, metabolic
Mhm.
syndrome
Mhm.
space. Um, and then the prevent calculator is also based on a much larger sample, a much larger database of patients than the pooled cohorts equations. So it's thought to be more accurate. What also happened with the prevent calculator is that it eliminates some patients who may be statin candidates because it may produce a more lax number. So, with the 2025 guidelines, the recommendation to start pharmacotherapy in stage one hypertension patients is not 10% anymore, but 7.5%.
Okay.
So if you have somebody who is at stage one hypertension and their 10-year ASCVD score, based on the Prevent CVD calculator, is 7.5 or greater, it's recommended
Okay.
to start first-line drug therapy.
Okay, so to recap that, those are really important changes. We moved away from the pooled cohorts equation calculator. We now have the new Prevent CBD calculator, which is available on the AHA website. So easy to find, easy to use. As is the pooled cohorts equation, do you think sort of gone? Like no real role for that calculator anymore? We're really fully moving over to Prevent, or is there any controversy around that?
I don't think there's any controversy about that. I think it's well, there's some discussion about whether the Prevent calculator should really replace the pooled cohorts equations. I think what we have to do is wait for the 2026 cholesterol guidelines
Ah,
um,
yes.
uh, to be published because those will be coming out fairly soon in the
Yes,
first quarter of
yes.
2026.
Yeah, yeah.
So I am actually very excited to see whether they will also endorse the Prevent calculator, and
Okay.
if they do,
Okay.
what kind of tweaks will they make to the
Gotcha.
recommendations?
Okay.
So
Okay.
is the pooled cohorts equations sunset? Not yet.
Okay,
More to
got it.
come.
But yes, we'll see with the lipid guidelines and whether they move to this prevent calculator as well. So, okay, but at least for hypertension for now, the recommendation is to use this new prevent calculator to assess risk. And then the threshold has gone down. So for patients with stage one hypertension, instead of the threshold for treatment being 10%, it's gone down to 7.5%. Is that right?
That is correct.
Okay, perfect. So that's an important change because patients may be going on to that website themselves and assessing their, well, they may not have all the data necessarily, but if they do, they're able to enter the information themselves and see where their personal cardiovascular risk is and be able to know, okay, go to the pharmacy and say, hey, or go to their pharmacist and say, I have a risk of 8.5%. Should I start treatment or not? And the pharmacist would need to be able to answer that question.
You bring up such an excellent point because the pooled cohorts equations were always publicly available,
Mhm.
and so is the prevent score. But in all my years of practice, I have never once heard anybody say, "Hey,
Okay.
Tom, I checked my own,
Yeah, yeah, yeah.
10-year
Okay.
score based on my labs and my values and everything."
Yeah, yeah.
I feel like we should. This is definitely an interesting point to make because patients can check their scores themselves, and
Hmm.
the American Heart Association website and the American College of Cardiology, which has the pooled cohorts equations, they all make recommendations and tell consumers and patients what to do with those numbers. So
Hmm.
I think one
Hmm.
of the things that we can do as a profession is basically just talk about this score.
Hmm.
If you're concerned, talk to your pharmacist, talk to your
Right,
doctor about
right,
what your score means for your health.
right, right. And
Yeah,
empowering patient education. I think healthcare is becoming so much more democratized and patients have so much more access to information than they had in the past. So it's, certainly possible in terms of patients finding it themselves, but also for our role, helping to make patients aware of what the tool is, considerations with it, how to use it wisely. And, everything in medicine, right, is gray. And so there needs to be individualization and shared decision making there. But yeah, that's a really important point to call out. And then I think you also were you highlighting the goal as well has shifted a little bit, or is that still pretty consistent in terms of what you were contrasting JNC 8 versus the 2017 guidelines now that I'm thinking about it. So the JNC 8 was 140 over 90 as the target. 2017 was 130 over 80 as less than 130 over 80 as the target. And that is reiterated in these most recent guidelines. Is that correct? Do I have that right?
there's actually a little tweak. When
Okay.
you
All right.
Yeah, so the 2025 guidelines are a little funny, and they're the first guideline I think that put a little gray spin on a recommendation because
Okay.
because when you actually read the recommendation for the 2025 guidelines, it says that patients should target a blood pressure of less than 130 over 80,
Mm-hmm.
and then ideally, if possible,
Mm-hmm.
less than
Mm-hmm.
120 over 80.
Mm-hmm.
And it's
Yes.
and that's all in one sentence as a class one recommendation.
Okay, so sort of getting at the idea that lower is better, again with caveats though, because of course there are all kinds of patient situations that may or may not warrant or be appropriate for that lower goal. And so that's probably where they were sneaking in some of that encouragement, but also needing to use clinical judgment along with that, right?
Clinical judgment goes a long way. Yeah, some
Yeah,
patients cannot achieve a
right.
lower goal for sure. Yeah, but yeah, I think it's a really interesting recommendation that they made, and I can't disagree with it, of course. So in general, we know that for every 5 millimeters of mercury that you lower your blood pressure, your systolic blood pressure, you get a 10% reduction in cardiovascular outcomes, and that is true for both primary and secondary prevention. So I
Okay.
see why they just want to go lower.
Mhm.
If it's safe to do and
Mhm.
if it's feasible for the patients, then the mantra basically is why not?
If it's tolerated, of course, again,
Yes.
I'm thinking in my mind, coming into my mind is the older adult, frail, maybe
Yes.
already on multiple blood pressure medications, at risk of falls. Obviously, the risk benefit there may change because you're thinking about risk of fall versus risk of cardiovascular outcomes, depends on their life expectancy, all of those factors, right, have to come into that decision too. So, but yeah, it is putting into perspective for the patient reducing your risk of a heart attack and stroke and giving those numbers that you said, Tom, I think is really a compelling message. It can help to make therapy justified if it's appropriate and safe to do so.
Absolutely.
Excellent. The other thing I'll just tie on to that discussion on goals is one thing I found interesting in the guidelines was that they added, I think it was a new recommendation or maybe a strengthened recommendation around I can believe it was a greater strength of recommendation around that less than 130 over 80 target, specifically with the endpoint of reducing dementia, reducing the risk of dementia. And so sort of highlighting that. And again, I think that's something patients may hear about or be interested in from a personal perspective. And again, if you're trying to work with a patient and figure out what's important to them in terms of management and outcomes, that could be another important point. Was that of interest to you, or am I recalling that correctly?
No, that's an absolutely great point because I'm a cardiovascular pharmacist. All I care about is cardiovascular disease. But yeah, hypertension is not just a risk factor
Right.
for cardiovascular disease. Of course, it is the number one cause of cardiovascular disease and the number one cause of strokes, of course. But it's also of high concern for dementia. High
Mhm.
cholesterol is a risk factor for early
Mhm.
onset dementia. High blood pressure is. So absolutely, there are other reasons that you want to lower your blood pressure besides just cardiovascular disease.
Mhm. Mhm.
It's just that cardiovascular disease is the number one killer of
Sure.
Americans. Actually,
Didn't agree
cardiovascular
with
disease is
that
the number one
myself,
cause of
right?
death in the world. So we definitely
Mhm.
want to reduce your risk of cardiovascular disease.
Right, right, right. Yeah, lots of compelling reasons. So
Right.
again, in those discussions with patients, just having that information, I think, is super important. So, what else from the guidelines? Any other key takeaways? I know we've already spent a good amount of time talking about them, but obviously it's a large document. Again, lots of updates and new recommendations to consider. But any other key takeaways that we should be aware of?
Yeah. I think because we definitely want to spend enough time talking about screening, treating, and things like that. So let's just focus on the treatment pathways.
Okay.
So the guidelines reiterate previous recommendations that if you have stage 2 hypertension, you want to start with two drugs from different classes
Mm-hmm.
that have different mechanisms of action. So the new guideline sneaks in a recommendation about potentially starting a one pill combination, which I know is a
Mm-hmm.
topic of interest for us today.
Mm-hmm. Mm-hmm.
So I think we can spend some time talking about that. And I
Okay.
think I think this is not I think this is not an outlandish idea because a lot of patients and providers have been very hesitant to start two medications at the same
Mm-hmm.
time.
Mm-hmm.
Very often you see patients with stage 2 hypertension in the real world starting just one medication. And I hear this a lot from my patients, and it is quite the inertia to overcome. I hear things like, if I start two medications at the same time, and if there's a problem or if there's a side effect, we don't know which medication caused it. So
Mm-hmm.
so therefore I would prefer to start one medication.
Mm-hmm.
And that is a very legitimate, logical thing to say from a patient. As clinicians, as pharmacists, I think it's important for us to reiterate some education about starting two pills instead of one when you have stage 2 hypertension. First and foremost, patients who start one pill therapies are less likely to progress to a second pill down the road because, again, there might be inertia, there might be loss to follow up, or there might be hesitancy. Um, and patients might feel like because the first pill didn't work, they might feel discouraged from they might feel discouraged to add another one, which
Mm-hmm.
totally makes sense and that resonates. So starting two medications off the bat makes more sense. And as pharmacists, we kind of know side effects of medications, right? Like if you start an ACE inhibitor and a thiazide at the same time, and you have low potassium, you kind of know which one's causing low potassium.
Mm-hmm.
Or if
Mm-hmm.
you start an ARB and a calcium channel blocker at the same time and you develop edema, you kind of know which one's causing edema, right? So these are things that you can definitely reiterate with your patients. We're trying to do this not because we want to cause side effects, but because we know that if we start one medication, you're less likely to achieve blood pressure control in the future. And I think an interesting point to make about single pill combinations is that surprisingly, when in studies in observational trials, there's no randomized controlled data to
Sure.
compare this, but observational studies show that when you compare single pill combinations to two separate medications of the same class and strength, you actually achieve better blood pressure reduction with the single pill combination. Which again,
Okay.
this comes from observational data, so
Sure.
take that with a grain of salt. And
Yep.
there
Yep.
can be a lot of reasons why this happens. Maybe patients are less adherent to the two medications, so maybe that's why the single pill
Mm-hmm.
combination works. Um, but what we see in the real world is that, in fact, taking two medications from different classes does cause problems with adherence. In the world of pharmacy, we're very aware of the concept of polypharmacy, right? If you take five or more medications, that's typically the definition of polypharmacy, then patients are less likely to take medications and they're less likely to be adherent.
Mm-hmm.
So being able to combine some of these medications into a single pill can really be of great benefit. The other thing to consider is we live in 2026 and prices change. I remember
Mm-hmm.
a time when any pill combination was out of reach because it was too expensive, wasn't covered by insurance. But nowadays, most combination pills are covered by insurance and they're actually tier
Mm-hmm.
one medications.
Mm-hmm.
So yes, financial considerations are important, but at the same time, we know that they're covered by insurance. Even out-of-pocket costs are sort of comparable to single pill
Mm-hmm.
medications. So starting with two medications is actually a great idea. And even when you consider costs, when you do start those two pill combinations, because you achieve better blood pressure control faster and you're able to potentially reduce cardiovascular outcomes over time, that actually does translate to cost savings for the patient. Because if you think
Overall,
about it,
okay. Right,
cardiovascular disease does cause
right.
loss of quality of life, does constitute a huge cost to healthcare and to the
Absolutely.
patient. So starting two medications at the same time can actually save you money in the long term.
And also the fact of needing to go back for repeat visits to check your blood pressure, see how it's going. If it takes time, as you said, that therapeutic inertia is a real issue. And so if you start it and sort of set it and forget it, then you may need repeat visits, refills, all of those costs add up too. And even just taking two separate pills, two copays for two separate products, that's in and of itself. And then also taking two physical tablets or capsules, whatever, by mouth, that's the literal pill burden for the patient too. So simplifying that regimen for them, making it easier for them. Yeah, I think it's really interesting you brought up the concerns around, I think the concerns that maybe many of us were taught as pharmacists, even that you sort of start one at a time so you know what might be causing an issue, a side effect, or how the patient's tolerating one product over another. But I really love that you called out we are very familiar with common side effects for these classes of medications used for hypertension. And so it's often quite not difficult necessarily to determine what might be causing an issue. And then, even the fact that most people are not at not going to get to goal with one medication alone. And so it's not that adding two at the same time is going to drop them to a blood pressure that's going to be very symptomatic for them necessarily, depending on where they're starting. But that's maybe less of a clinically important consideration than we might have thought, in the past. Do you agree with that sort of thought? Or
Yeah,
what would you say
yeah,
about folks
absolutely.
who might be concerned about starting off a patient, say they are stage 2 hypertension eligible for starting combo therapy? How would you help the patient feel reassured about starting and not being at risk for substantial blood pressure lowering or substantial side effects? How would you educate that patient?
That is an excellent point to make. Yeah. So, I think again, I'm just kind of reiterating the fact that pharmacists are drug experts. So, the rate of side effects is obviously not something to ignore. We know that
Mhm.
side effects from medications do happen, but when we're treating high blood pressure, especially stage 2 hypertension, we got to think about the risk benefit, right? So
Mhm.
what I like to tell my patients is I would never start a medication that I think would be dangerous for you. I
Mhm.
always want to weigh the risk and benefit. And when we're talking about the benefit, it's, reducing the risks of myocardial infarctions, heart attacks, strokes,
Mhm.
things that don't just cause, quote unquote death, but things that can cause a lot of debility. So there's substantial benefit. And the side effects that we're talking about are comparatively very, very mild. So we're talking about things like, some electrolyte imbalances, some edema, um, the biggest fear that a lot of patients have surrounds things like orthostasis, syncope,
Mhm.
just
Yeah.
dizziness, lightheadedness,
Yep.
and falls. A lot of my patients are older than the typical population. On average, a veteran is in the cardiovascular clinic is about 10 years older than somebody in the general population. So I hear this a lot from my
Yeah.
patients, and you can really use your power as a pharmacist to re-educate about, these very, very real concerns. If I take two medications at once, I might fall down.
Mhm.
I might, hit my head. A lot of my patients are on
Mhm.
blood thinners. Um, so you can use your power as a pharmacist to choose the right therapy for that patient. So let's talk about some clinical aspects of choosing the right therapy for the right patient. So let's think back. Let's put our pharmacy student hats on or our residency hats on and think
Mhm.
back to the accomplished trial that looked at patients at high cardiovascular risk. And that study found that combination ACE inhibitor and calcium channel blocker was superior to an ACE inhibitor thiazide combination. So my favorite go-to is the combination, for example, benazepril and amlodipine, because that's a single
Okay.
pill combo. It's fairly cheap. It's covered by most insurance companies.
Mhm.
And when we think about the side effect of lightheadedness or dizziness, it's a very, very it's a very broad term, right? That can be overcome by simple things like proper hydration. A lot of elderly patients don't drink enough water, which is a very, very real thing. Um, And then the syncope or the presyncope or the lightheadedness or the dizziness that occurs when you take certain medications doesn't really have much to do with the magnitude of blood pressure difference. It has more so to do with that orthostatic hypotension, with that drop in blood pressure when you stand up. So when you think about medications that are more prone to orthostatic hypotension, ACE inhibitors and calcium channel blockers and angiotensin receptor blockers are the least likely to cause this side effect.
Okay.
Diuretics are more likely to cause this side effect. Beta blockers are much more likely to cause orthostatic hypotension than ACE inhibitors, ARBs, and even thiazides, which might be very surprising to a lot of people because, hold on, beta blockers don't cause a big drop in blood pressure. That's why they're not first-line medications for blood
Hmm.
pressure. So why do they cause so much dizziness? Because again, a lot of patients and a lot of providers think about these side effects in terms of magnitude of blood pressure difference over time,
Hmm.
which is not true. It has more so to do with that sympathetic inactivation
Gotcha.
or the vasodilation or the volume depletion, about the change in blood pressure when you stand up, as opposed to chronic changes in blood pressure over
Okay, makes
someone's
sense.
therapy. So these are some really important things that you can point out as a pharmacist when you're starting two pill combinations. You know, we know that the rates of side effects are low. We know how to predict them. We know which medication can cause which nuanced side effect. And then you can talk about the other benefits besides just reducing blood pressure and besides just reducing the risk of cardiovascular events, right? If you have somebody with renal disease, we know ACEs and ARBs are of huge benefit, especially if you have diabetic kidney disease. Or if you have somebody who has cardiovascular disease and they present with angina, we know that calcium channel blockers help reduce the symptoms of angina. So that's another benefit, right? So there's other reasons why you might want to start certain medications
Mm-hmm.
in certain patients.
Sort of this two for one benefit in some cases, and also thinking two for one in terms of just starting right out of the gate, two combo meds for a patient with stage 2 hypertension. And again, I love the reassurance you provided there, the way you put it in the perspective of how you would talk to a patient. That's really helpful. And as you said, clinical benefits, but also adherence benefits, cost benefits, daily impact on life benefits. So lots of great considerations there. And I think that was an important change in the guidelines, sort of highlighting the role of single pill combination therapies, but also there was that supplemental scientific statement to support that as well. So for our listeners who want a little more detail about that, that's another great resource to refer to. Um, any other sort of considerations with combo therapy in general, and anything to sort of wrap up that side of the discussion before we move on?
Yeah, I think let's move on to the race-based
Okay.
recommendations because the combination really comes into play
Yeah.
here as well. Um, so much like the prevent calculator has gone away with race-based calculations, and they actually employ something called the social deprivation index. The new guidelines, the new 2025 guidelines, also go away with race-based antihypertensive medication recommendations.
Hmm.
And I love that. I love that we're finally moving away from this ancient misunderstanding that Black patients, because have low renin activity, therefore they will not respond to ACE inhibitors and ARBs. Um, this was based on old data from the 80s, which was unfortunately confirmed by studies like the ALLHAT trial, where we saw that thiazide calcium channel blocker combinations and sub-analyses were better for Black patients as compared to ACE inhibitors and ARBs. And this kind of reinforces the idea, take secondary outcomes, sub-analysis with a grain of salt, because studies are not powered for
Hmm.
those. So all of that kind of reinforced this idea that because of these studies, because of the low renin activity, Black patients are less likely to benefit from ACE inhibitor and ARB therapy, which new data shows that that's absolutely not true. So first of all, when we look at the stratification of hypertension in the United States, we see that Black patients are at the highest risk of having uncontrolled hypertension. So delaying potentially beneficial therapy, like
Yeah.
ACE inhibitors and ARBs in patients
Yeah.
who may have things like kidney disease or diabetic
Mhm.
kidney disease, is really problematic. And then because we know that, for example, thiazides may cause a few more side effects, because we know that calcium channel blockers may cause some potential side effects. Delaying therapy with ACEs and ARBs is problematic. So
Yeah.
combining medications in these populations is crucial because first and foremost, there is no calcium channel blocker thiazide combination pill out there right now, as of the recording of this episode. So you have dozens of combinations, and it's funny how a single calcium channel blocker thiazide pill does not exist. There's triple combinations now that have an ARB, the thiazide, and a calcium channel blocker, but no single pill calcium channel blocker thiazide combination, which I think is really funny.
All right. Well, yeah, I mean, that's the other consideration too with the combo therapies is knowing what options are available and whether you can or can't combine the preferred therapeutic options. And you talked about ACEs or ARBs plus calcium channel blocker or thiazide as good options, not going to an ACE plus an ARB. That is not a good option. I don't think there's any combo pills available with that, but just wanted to reiterate that too, because that's sort of a misconception, I think, from many years ago. And yeah, but we do have plenty of combo pill options available, and it does make it easier to not have to maybe worry, quote unquote, about the race-based considerations that were previously in the guidelines. It's a bit more straightforward now. We have more options available for all of our patients.
Exactly, yeah. Just follow the guidelines, follow the comorbidities, follow the conditions. Don't follow
Right.
antiquated race-based recommendations.
Excellent. Excellent point to summarize that with. So I I know we're running out of time, but I do want to quickly touch on this other scientific statement from the AHA that was released at the end of last year also, which is highlighting the cuffless blood pressure measuring devices. So things like smartwatches or fingertip monitors, there's rings, all of these different devices. And I think this is sort of a hot topic that, again, pharmacists might be asked about because people are always looking for ways to, more and more interest in sort of monitoring your own data, but also we know the importance of monitoring and assessment of blood pressure in diagnosis, but also ongoing monitoring. And so helping patients find an appropriate device to monitor if they're interested in doing so, or for those people who are just sort of those interested in knowing what their numbers are. Where does that scientific statement sort of end up in terms of the role of these cuffless devices for measuring blood pressure?
Yeah, this is kind of an easy one. So
Okay.
the 2025 hypertension guidelines specifically say there's no benefit of using cuffless devices, which,
Okay.
if a patient comes to me and they say, there's this cuffless device, it's either like a ring or like a pulse oximeter type of a device or a smartwatch that can, measure someone's blood pressure. It's very convenient for a patient, right? Because
Yeah.
they don't have to sit down, put the cuff on, follow all the procedures.
Right.
So it's very convenient for patients, and they would, if they have the technology, then I understand why people would love it. But unfortunately, they're just not validated. They
Hmm.
they have to be they have to be validated before we can make any recommendations for using cuffless devices. The other thing is, which people don't realize, which kind of goes hand in hand with convenience, they have to be calibrated correctly. So it
Hmm.
does take time to calibrate them. You have to do it once in a while. And a lot of our patients, unfortunately, use typical cuff devices inappropriately. This is another topic we can talk about for hours. But if
Hmm.
they're but if they're using if they're calibrating their devices with inappropriate techniques, then we're just we're left with inaccurate numbers.
Hmm.
Um,
Hmm.
so I think the biggest takeaway is cuffless devices exist. They might be very convenient, but unfortunately, we have to wait for more validation studies to confirm whether they are useful for our patients. As of right now, we unfortunately have to keep reiterating using a typical blood pressure cuff with the proper procedures. Sit down, relax, keep your feet flat on the floor, relax your back on the backrest, wait for 5 minutes, and then check your blood pressure, and then do it again after a minute and take the average of
Mhm.
those two readings.
Mhm.
While inconvenient, it is the best thing that we have for making sure that we check our blood pressure the right way.
Mhm. In terms of making therapy decisions, because of course, like you say, patients may be interested in their devices and what they're showing, interested in those numbers, but in terms of us as clinicians being able to make a therapeutic recommendation or change, having the sort of that accurate, validated approach that you just described is what we need to go with. And just basically being aware it's a bit too soon for prime time in terms of using those cuffless devices for evaluating or gauging the effects of therapy then.
I will say this, if it starts the conversation about screening for hypertension, and if
Yeah.
somebody comes to you and says, hey,
Yes.
I have this cuffless device and it shows a blood pressure of 150 over whatever, over 90, hey, that at least started the conversation, right?
Yes. Excellent point. Excellent point. Awareness is always a good thing, right? Because you mentioned right at the beginning of this conversation, many people with high blood pressure in the US don't realize they have it. And so any cue or clue that starts that conversation is a good thing.
Exactly.
Okay, perfect. So we've talked about a lot today, and in terms of some key takeaways or high level summaries, this is the Game Changers podcast. So what are some of the key game changers based on everything we talked about today and everything that you know about the hypertension guidelines and these statements? What are I normally try to nail it down to one, but I feel like we have a few key game changers here. So what would you want to summarize our discussion with today?
Yeah, absolutely. I mean, we talked about these guidelines for a long time because there's just a lot to talk
Yes,
about. So,
yes.
the key game changers, the key things, if you're a pharmacist, to really, really remember, start screening early. And when I say start screening early, don't just think about blood pressure numbers. Think about all the other things: thyroid
Mhm.
conditions, renal disease, BMI, so obesity, obstructive sleep apnea, primary aldosteronism. Like really think about early screening for secondary causes of hypertension and for comorbidities that might contribute to cardiovascular risk. And then once you do that screening, in the very beginning, I talked about how multidisciplinary approaches to medication therapy management and to patient outcomes are of high importance to me. So if you're someone who practices in the community, if you're somebody who practices in the hospital, it doesn't matter. You're a pharmacist that can connect patients with other providers, with specialists. Pharmacists are the number one trusted profession in the United States. I hope that still holds true. And we're the most accessible profession in the United States. So you are the first person, the patient will typically talk to about their conditions. So definitely have that discussion with patients about referring to a specialist if you believe more has to happen for screening purposes. And then the other game changer that I think is a really important takeaway is the actual blood pressure cutoffs. Screening for blood pressure. Remember that if you're at stage one hypertension, now the recommendations are to use the Prevent CVD calculator on the American Heart Association website. And then if you have stage two hypertension, really consider starting two medications at once, and if possible, use a single pill combo to help with that. Again, going away from race-based recommendations, just kind of focusing on the comorbidities and on what patients want. Talk to the patients, see
Yeah.
what medications make most sense to them, based on side effects, benefits, and things like that. And then follow-up is really important. We talked about inertia. We talked about problems with titrating therapy. Adding combination therapy, adding medications on is of greater benefit than titrating medications themselves. So when you have somebody with high blood pressure and you think that they need more reduction, add on a medication instead of titrating that first medication. If the blood pressure is still uncontrolled on two medications, you can consider adding a third one and then titrating to target doses. Because when you have more medications on board with complementary mechanisms, that benefit in blood pressure reduction will be greater.
Mhm.
That is a lot about today.
Yes, but all such important points. We could honestly spend an hour, I think, on each of those individual topics, but I love your recap. Prevention, your recap was screening. So in terms of screening, thinking about those comorbidities and other screening that needs to happen and referral, multidisciplinary care. Uh, initiation of treatment when appropriate with a combo pill, if it makes sense to do so, and thinking about the broadening of menu of options that we have for patients potentially as those race-based considerations were removed, and the importance of avoiding therapeutic inertia, either when starting or when adjusting therapy. And I really love the idea of having more comfort with starting a combo pill. That is something that I think may take some getting used to, but is an important change in the guidelines to highlight. And then the importance of appropriate monitoring and follow-up and continuing to support patients in their care, because obviously we want to make sure therapy is working for them and helping to improve those outcomes, and doing so with an appropriate blood pressure monitoring device, which is not a cuffless device per se. So does that summarize it? All in all, any other questions?
We can talk for hours about this. Yeah, that is an excellent summary. We haven't even covered all of the new recommendations in the
I know,
guidelines, but I think we covered
yeah.
the most important things for pharmacists.
Yes, we're gonna have to have you back for another discussion later on.
Part two.
Thank you so much, Tom. Your expertise is amazing on this topic, and just love your passion for optimizing care for patients and multidisciplinary care. I just think it's fantastic, and you're really supporting pharmacists and all that we can do. So really appreciate your expertise here. Thank you.
Thank you for having me. This was a pleasure.
Excellent. Well, we did talk about a lot today. So all of these will be summarized in the practice resource that will go along with this podcast on the CEimpact website. So be sure to check that out, because again, lots of great tips here from Tom, and we want to make sure we have those takeaways for you to work with in your practice. And listeners, be sure to claim your CE credit for this episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.